But that brings me right on to our next part of this session. So that's the discussion with Dr. Cliffe. So thank you so much for joining, Adam. I hope that this will be fun and useful for everyone. These are some impressive figures that we've got here, so I'm going to talk through them. Number one is the 200K in savings after implementing a total triage model. I know, Adam, that you've got a couple of caveats that you'd like to make, which I think are definitely necessary in order to be completely transparent to people. But also what I've pulled from the online reviews for your practice, which I thought really told a good story in terms of online consultation. So we've got one here, which is phoned last Friday for a prescription without an appointment. The receptionist was extremely helpful. I sent in a photograph, which was forwarded to the doctor, who sent the prescription through the same day, and it was a marvelous experience. And then another one, this is directly from the NHS reviews, filled in the online form for a consultation, received a message the same day with an appointment for MSK services the next day. Fantastic service. So we know that your patient list size is around 8.4K. We've got the triage workflow, which I'll let you speak to a bit more on. There's a couple of points that we thought would be useful to touch on today. So number one would be implementing the system, talking about staff morale, patient satisfaction, and also those cost savings in terms of those benefits. But the first question I've got for you, kind of relating to that first icon, was what was that process like in terms of making a change to total triage?
Yeah, so thanks for having me first. So I'm always pleased to try and help. If people other practices are struggling or trying to improve things, I'm keen to try and share our experience really because we definitely learned a lot from it. Um, it might be helpful if I just talk a little bit about sort of who I am and the practice and what we went through and what our journey was like really because it was a bit of a process. And then we can sort of go on to break down, some of the outcomes and results we've had out of that, but kind of financial and the impact on the staff well-being and morale and all of that stuff as well.
Sounds good.
So I'm a fairly new partner, really. I finished my training in October of 2020, so it was like right in the middle of that COVID era, and then I took on a partnership a year or so after that. And it was that time where probably everybody can relate to the fact that we were just getting busier and busier and busier in primary care as the COVID pandemic was sort of drawing to a close. And it felt like we were all really struggling to keep up with the demands on the service, and we were getting more and more requests for appointments. And at the time, we were using we'd come from a sort of a traditional access model where people were phoning up and walking in, and the reception staff were kind of divvying up the appointments as best as they could. But we were also experimenting a bit with this online form and trying to get patients to use the website to request consultations. But it felt like in those few months of sort of it was around sort of 2021 when it was starting to build up, and through 2022 we found that we were just struggling to meet that demand and felt like we did not have the capacity in the workforce to do that. So we were turning the form off earlier and earlier every day on the website, and we were starting to redirect patients to other services, and the waiting time on the phone was really long. And the reception staff were trying to manage that when people were phoning up and they couldn't wait, and there was no appointments left, and they were shooting messages around all of the doctors trying to get advice on what to do with these patients, and usually getting several different answers back. So it felt like a really difficult time. And I know a lot of the staff were sort of felt like they were approaching burnout. And even, as clinicians, we felt the same. We felt like we were under a lot of pressure. So we were trying to do things as a practice to improve that. And we were using a lot of locums around that time, trying to help us to get more appointments to see the patients. And we took on another salary GP, and doing things like that to try and help. And it felt like no matter whatever we tried, we were just drowning, and we were struggling to keep up with the work demands really. And then it got dramatically worse over quite a short space of time when we realised that the bank balance was low, and we did some projections and worked out, how our forecasting was looking, and we were on track to bankruptcy really. So that added a lot of stress, as you can imagine, especially as a new partner. So I did some crisis meetings, and essentially we redesigned the service that we offer, and particularly with regards to the way people can access the care. And that essentially was to implement a total triage model. And I know the word total triage, some people like that term. I'm not sure about it. So often you find patients worry it means that they just won't get to see a doctor, and you find doctors worry that it means you're just going to be sat clicking buttons and moving people around appointments, but without actually doing any kind of clinical work. So, you know, that's the term might not be the best for some people, but essentially what we were trying to do is make sure that each patient sees the right person in the right time frame, and to do that efficiently and to do that well. Now, because we were under such a lot of financial pressure and you know, work demand pressure, we didn't have loads of time to worry about it and think about it. We created a system and we implemented it, and we crossed our fingers and hoped that it would work. And actually, it worked dramatically well. And it was probably at a time that was just a little bit before a lot of other practices made a similar change. So because we had such good results, we ended up sharing that through various platforms. And over the years since then, I've spoke to quite a few places about implementing different access models, and seeing lots of benefits to lots of places about that. And I suppose the key thing is that obviously we all work in really different environments. So you know, we might have people here with practices of 40,000, or people with a practice of 1,000 patients, and you know, we've all got different demographics of our patients and different demands they'll put on us, different resources in our staff that we can use, and different skills in our staff. So we're all working in different environments, and I don't think it's fair that you could design one system that works well for everywhere. But I think the key thing is to look at the principles of how this kind of system can work, and then figure out how that applies to your practice with your patients and your staff, and to, you know, tweak and adapt things to make it fit well for your environment, really. So essentially what we did was, when we redesigned the access model, and obviously there's a lot to talk about here, and I'm conscious that we don't have heaps of time to talk about the nuts and bolts of exactly how we run the system. But if anybody does need any more information about it, when I'll be doing a series of webinars over the next few weeks for much smaller groups, where Accurx will send out some details of how to book onto those, and you know, we can go through the more specifics of exactly how our system runs in those sessions where it'll be a bit smaller and we've got a bit more time on our hands. But essentially what we did was, we firstly decided that we needed to streamline the way patients were approaching us. So instead of having people walking in or phoning up or using the form, we said that everybody is going to have to use that same consultation request form. And the majority of our patients can do that by going on the website, you know, filling in the form themselves, and that comes through to us. But there are some patients who can't do that, maybe because they don't have access to IT, or they've got vulnerabilities or disabilities, or maybe they're homeless, or, you know, a long list of reasons why people couldn't do that themselves. And for those people, they're, you know, totally, we're happy for them to call us or walk in just as they would have done before, and we'll have the reception staff fill out that form on behalf of the patient. So it still comes through the same workflow, and comes into the same inbox. So we just have one incoming stream of consultation requests, and that's going to make it much easier for us as a practice to look at that list and work through them in a timely and fair way. So we're dealing with things appropriately and in the right order. Now, to manage that incoming flow of consultation requests, we decided that we were going to create what we call the same day team, and we put them in a room upstairs in the practice that we call the hub. And we moved our practice manager out of her office and redesigned it as a hub. And in that team, we've got always one member of the admin staff, so one member of a care navigator or a receptionist, or whatever term you use in your practice. But we always have one member of the admin staff, and then we've got 2 or 3 clinicians, and it depends a bit on what time of the week or what day of the week we're talking about. But we've always got one GP, and we've got 1 or 2 ANPs in that team as well, and we're all sat together in the same room. And the first stage of that triage process is done by our care navigator, by the admin staff. So they're working through that list in order, looking at each consultation request, and they're asking 2 questions. So the first question they're asking themselves is this a patient that could be seen or is more appropriate to be seen in a different service? So if it's something that could be seen by the MSK team or community pharmacy or maybe A&E or maybe the hospital specialist or podiatry or the eye service, long list of other places that people can go to seek healthcare, and if it's appropriate to be sent to one of those places, they're redirecting them at that point to one of those other services. And that's something our reception staff are excellent at. And those services change and adapt all the time, and they're really good at kind of staying on top of that and sending all those patients that are more appropriate for those places elsewhere. Now, if it can't be sent elsewhere and it is a patient that should be, for us as a practice, it's more appropriate to be seen by us as the GP, then they're asking themselves the second question. And that second question is just, is this a patient that is poorly and needs to be seen today? Or is this a patient that it could wait a few days for a routine appointment? And it's really key, I think, to have that distinction of the incoming requests and putting them into categories of does this need an urgent response or is this a routine problem? And separating out that workload into urgent and routine really helps us, as we'll go on to talk about, with our workforce planning and our ability to deliver the right care for our population as a practice. Now, there's other places I know that do things slightly differently, and they might use like a 3-layer system with like red, amber, and green priorities and things. And again, that's sort of up to what you feel works well in your practice. But for us, we like it just as a simple: is it urgent same day, or is it not? Is it routine? Can it wait a few days? Now, for a lot of those consultation requests, we find that the admin staff member can make that decision perfectly well, and they have been doing by answering the phones and dealing with this over the years, and they've got some experience of it. So for some of those things, if someone rang up with chest pain, they would know that's got to go to A&E. If somebody rings up saying the kid has got a fever or a temperature, then they know that probably needs to be seen that day. If it's someone who wants to talk about their HRT prescription, maybe that can wait for a routine one. So a lot of those things, they can make that decision and they feel confident to make that decision. But we know that obviously it can be a lot more complicated than that. And, sort of at least sort of 25 to 50% of the consultation requests are a bit more difficult to decide if it's urgent or routine. And the admin staff are not clinicians, they're not clinically trained, and we don't expect them to make that call. So if they feel unsure or uncomfortable at all, then they're asking the clinicians in that room who they're sat with, they just can ask the person next to them, what do you think about this 40-year-old with abdominal pain? Does that need to be today, or could that wait for the next routine of face-to-face or whatever it is? And the clinician will be discussing that, and we'll work it out together as to whether it should be urgent or routine. And if we need more information, then using Accurx's messages, we can get that information really well by sending them questionnaires or just free texting and asking them for a photo or for more information to help us to make that decision. Now, if it's for a routine appointment, then the patient's going to get a text, usually with a self-book link, or maybe we'll just book something in directly and tell them when that appointment is, depending upon the circumstance. But if it's for a same-day urgent appointment, that's getting put onto a list on our EMIS system, and the clinicians in that same-day team, they're going to work through that list one by one, just ringing the patient, bringing them in for a face-to-face, seeing them, dealing with them. And most of our acute, urgent consultations are done by the clinicians in that team. So the doctor and the AMPs, they're not sat there doing a lot of kind of clicking and triaging and booking appointments. We tend to actually be doing kind of urgent, acute clinical work really on our days in the hub. So that's a kind of essentially how we set it up. I know there's a lot to talk about, and as I say, we can do that a bit more in the kind of ambassador sessions. And talk a bit more about how that might work for your particular practice. But by creating that system, we found that first thing was that it just took the pressure off everybody. So we felt that the reception staff suddenly felt more supported, and they didn't feel like they were having to make uncomfortable decisions or redirect people to other places. And because they had that clinician sat next to them, that if they at all didn't feel sure, they could get that support and get the questions answered immediately. I think it really just took the stress off them. and really helped to kind of bring up staff morale a bit, really. The other thing that was dramatic was that by doing this this kind of system and separating our urgent work from our routine work, we were able to structure our workforce to mean that we can always provide enough appointments to deal with our urgent on the day consultation requests. And that, you know, we know that, I have to be a bit careful about what I say, but I know that we're working in a primary care system that's been underfunded for a lot of years now. And we know, you know, in the NHS as a whole, waiting lists have gone up and up and up for the hospitals. A&E waiting times have gone really long. And we're feeling that pressure in GP, but we haven't really had any option to increase the waiting list. So we've decided that given the resources that we've got, the way we want to prioritize our workforce is to make sure we've always got enough clinicians to deliver that urgent care for people who might be poorly or might be vulnerable and they need that urgent same-day response. If you've got a non-urgent problem, so you need, you know, to talk about medication, or you want to follow up about your ongoing issue that you've had for a long time, then you're going to be booked in for a routine appointment. And ideally, we want that wait to be about 1 to 2 weeks for your routine appointment. But if we don't get more resources into the system and we're struggling, then that waiting time might go up because we'll be putting more of our clinicians in that urgent team to deal with the poorly people. And having that distinction between your urgent and your routine work, it allows you to get control of that workflow and to really help to sort of manage that capacity problem. And we weren't sure how that would play out. And obviously, as I say, we had to rush that system in. But we found that by doing this, and it's made us so much more efficient at dealing with people quickly and efficiently, and also using all of our community resources to the maximum potential. And anything that could be booked in elsewhere, like a pharmacy or a PCN appointment or whatever it is, they're getting sent to those places. And that increased efficiency has had a dramatic effect on our ability to keep up with the capacity and the demand problems that we faced. And a lot of that is what's led to the benefits of the system, really. So I've done a lot of talking there, Hannah. Does that all make sense so far?
Yeah, absolutely. And that's completely perfect. So talk as much as you want. It's you that we want to hear
Yeah.
today. I would also say to everyone who is on the call, please do submit some questions in the Q&A as we go through. So that way we can kind of get some more information that maybe is like relevant to the people who joined today specifically. But as you said, Adam, they do have the access to the ambassador calls if they're keen to go into like really specific detail. One of the questions, just on the back of what you said just then, was that I had was just in terms of what do you think it would have been like in terms of making that change or that switch and really seeing those benefits if your practice hadn't really been struggling so much at the initial point of looking to change? How do you think that would have affected the
Um,
journey?
Well, I think, I mean, I've spoken to lots of practices who followed us in this kind of journey and made their own changes. And I tend to find that people who are have got less of a kind of urgent need to change, they might spend a long time deliberating and worrying about what's it going to be like, what if this happens, and often, you know, people worry about what if by keeping this form open and using this triage system, we just drown in demand and we just can't keep up with the demand. That's a really common worry. And most places that I've spoken to haven't really found that. And it's just about trying to plan your workforce to make sure that you've got enough people in that urgent same day team that you're not drowning and that you are managing it. And if that means the waiting list for the routine appointments is increased, then you know, that's just unfortunately the service that we have to live with at the moment with the funding in the system. But I think if we'd had a bit less time pressure, we maybe would have spent a little bit more time explaining it to the patients really and trying to bring them with us on the journey. That was the one thing we learned. We maybe didn't communicate the change as well as we could have done. But when we made that change, firstly we designed the system, and then it's really important for any system change in any service really is to involve all of the people in that team. So then we had some meetings with all of the staff, talked through the system, and said, you know what, how do you think it'll be? What, what are the pros and cons? Is there any worries? And we made sure that we addressed all of them, because other members of your team will see problems that you can't see. The reception staff had input and thought of different things that we hadn't considered. And then we tried to implement it. We did a few trial days, which was a bad idea, because it made it confusing, because on a Monday you had one way of contacting us, and on a Tuesday it was a different way. And we did 1 or 2 trial days, and it felt so much better on those days that we just said, right, get rid of the trial, let's go full time on it. And I would actually say, it'd be better to design your system and then just bite the bullet and just implement it. And if things go dramatically wrong, you can always revert back to the old way if you need to. But in my experience, I've not really come across anyone having to do that. Everybody worries more, and once you've implemented it, the pressure is relieved really quickly, actually.
Yeah, that's really good to hear. And I think very reassuring when it comes to this change of like the method of contact for patients. It can feel really overwhelming, and there
Mm,
is that real like present risk, I think, for people. But what I think is really pertinent to what you said is the fact that you're like trying it and also kind of exploring the different avenues that can, and it's different for every practice, as you've said,
mm,
that actually it needs to kind of be navigated. What I thought was also interesting is like the way that you've communicated with your staff and kind of brought them along on the journey and that process, and how they all kind of had to feed into it. Um,
mm.
I guess what I'm interested in also in hearing is like the impact on the morale and maybe even like the patient satisfaction. So staff morale and the patient's assessment of it all
Mm.
as well.
So the impact on staff morale was one of the biggest things, really, because we can't, it doesn't, we can't create a system that we're not happy to work in. And I know the job can be stressful sometimes, but it's up to us really to design our service in a way that we can enjoy being in work, and feel like we've got a manageable workload, and frankly that we can just have a bit more fun again. And I know in the before we made this change, we spent a lot of time sat in your room by yourself, feeling like you couldn't keep up with the workflow, and you were here for 10 hours a day, non-stop working. Whereas now, I mean, the way we structure it is we'd only ever do half a day in the hub at a time. We don't tend to do many sort of full days, but you might do half a day there and half a day of doing a routine session. And having that break in your workload, and having a chance to, sit together, and we do, it's just nice to see your colleagues, and we have like stupid things we do there, and do things that are just fun again, and it just feels like being part of a team, and we actually enjoy it. And there was a lot of anxiety from some members of the team that how they would find it in that hub, and they thought, oh, this is going to be, it'll be under pressure, and I don't want to, have to be involved. But really quickly, within one shift, everybody loves being in the hub. And actually, that's the people fight over the shifts now, so everybody's defensive of their time there, and they want to be there. And people prefer that to either, being on the phones or doing your routine list, or something like that. So that it tells a story in terms of the effect on staff morale, really, and the way that changed for us.
No, that's huge. And I think there was actually a question that's come through from the audience, which is that they've had staff members who are maybe ambivalent or really against it, particularly maybe like GP partners.
Mm.
How, if you had any advice of convincing different people within different areas of their practice, what would that look like?
Well, I mean that's a common problem as well, and often it can come down. You have to look at the reasons why, I suppose, and sometimes it feels for people like they are, if they're working at 100%, and they're stressed already. It feels like trying to implement a change, and the fear that if that makes things worse, you won't cope, and you don't have the resilience to cope. That's sometimes where it comes from. The other thing is that sometimes it comes from people who are maybe a bit less progressive, and sort of more traditional in their approach, or maybe a bit later in their careers, and kind of reluctant to change what they've known and what they've done for the whole, the last 20, 25 years. I was lucky really in my practice that the other partners are all quite forward thinking, and really encouraging of making these kind of changes. So it's not a particular barrier I faced, but I think the key thing is to kind of talk about the worries and the pros and the cons, and have that discussion and try and reach a consensus. And sometimes it can be you know, it can be helpful to either have like a more one-to-one discussion with a practice that's already doing it, or I know we've had some practices local to us in Greater Manchester that have actually come in, you know, and sat with us for a morning and actually watched what we do, and that tends to reassure people as well, because they can see, oh look, this is working and this is how it works, and gives them something to aim for. So I think it's just exploring the issues and making sure, you know, you're constantly considering, are you doing things in the best way you can, and can things be improved, and not being scared of trying things, really.
Yeah, absolutely. I think maybe that's like a really key point is the to try it almost. And as you said, you can always go back. And perhaps that's it. It's very natural to be risk averse when you're working in healthcare,
Mm.
and to try and avoid making things worse, especially when things are in a state of crisis potentially already. So I think that's really pertinent as well. And obviously, staff aren't the only ones who are using this system, but also patients. And there's a question here that's come through, which is, do you get many patient complaints, or I guess how have patients really been using it?
No, I mean, yes and no. Like, you're always going to have some patients complain, no matter what you do. So when we first changed for the first month or two, I think there's sometimes people on the phone would say, you know, oh, you know, I don't want to do the form. I can't do it. I don't have my computer with me, or I can't use a computer, or whatever they'd say. And I think that partly that was maybe down to them thinking that they would get a better or quicker service if they spoke to someone over the phone, which in the old system they probably would have, to be honest, because you know, stuff was getting dealt with in different ways, and actually it wasn't equal. So I think people took a while to get round to that idea. But generally, you know, our reception staff did a great job at answering the phone, as you know, saying, okay, yeah, if you can't do it, that's not a problem. We can just do the form on your behalf, and you'll be contacted, you know, with your appointment, or you know, by a clinician. So once the patient then realised that, oh, they're just going to do the form on my behalf, that usually they just say, oh, forget it, I'll just do it myself, which is fine. And we found, you know, the uptake of people just doing the requests themselves is great. And we did have some patients who, you know, maybe did struggle with the IT or didn't feel confident. So we actually got a local charity to start running some kind of IT literacy classes on once a week on a Wednesday. And if the patient rang and said, I can't do the form, we said, oh, we'll come down on Wednesday afternoon, and we've got someone who'll talk you through it and show you how to do it. We had loads of uptake on that, and some really nice, like, heartwarming ones. You know, we had a 96-year-old guy who said, oh yeah, I'll come to that. I want to learn how to do it to help my wife. And, you know, he came down and he learned how to do his own consultation requests. And so I think, you know, looking at things like that you can do is helpful. But by and large, we didn't get loads of complaints about it. And actually, now you look at the service that the patients get, and they submit a consultation request, and they tend to get a reply within an hour or two most of the time, either with their appointment or a self-book link, or they get a call from a clinician and get the problem sorted out for them, or get told to come down and get to see someone. So, and you know, they're not spending 90 minutes on the phone anymore trying to get through, and then losing their head when they get told that they can't, you know, see anyone that day. Our waiting time on the phone now is, you know, it's less than 2 minutes, and it has been ever since we changed, really. So, you know, for the patient experience on the whole has been good. However, you know, any public service job, you are going to get some people who don't get what they want and complain, and that's, you know, just part and parcel of GP, unfortunately, I think.
Yeah, and I think there's like pushback is inevitable with new change, especially when
Mm.
people feel like they really rely on that service. But I think what you've shown almost is that as it plays out, like the change has happened, and then as time goes on, people get more used to it and kind of adapt. Um, One other thought that I had was, well, just to talk, and there was a question through here as well, to talk through this 200K figure and kind of where
Mm.
it came from.
Yeah, so the number was a surprise to me, actually. So obviously the at the time that we implemented the system was a financial crisis for us as a practice, really. And we knew that by changing the system, we would be helping with the capacity problem, and part of that came out of our, you know, we could no longer afford to employ locums. Um, so if you look at the the bulk of the cost saving was that in the year preceding making this change, we'd spent 140K on locums. Since making the change, we've spent zero on locums. We haven't really had to employ any. And that's because we can always provide enough clinicians in the same day team to manage it. So, we need two clinicians really most of the time, maybe slightly more in the winter, but at the moment we need two clinicians to manage that urgent on the day demand. And as long as we've got them, we don't need a locum to come in if somebody's off or if we've got lots of annual leave or anything. So that saving has been huge. So 140K of it comes largely from that. And the other things that we did was we'd taken on an additional salary GP on a short-term contract, again, because of the capacity problems we were struggling with. And we didn't, unfortunately, we couldn't keep her on. So we had to let her go, which was really sad at the time. And it wasn't something that we would want to do again, really. But that saved us 70,000 as well, that we were no longer paying on her salary. And we also reduced the partner session because we were trying to make the cost savings to stabilize the bank account, really. So one of the partners volunteered to reduce the session, and it's hard to put a figure on that because it changes year by year depending upon your profit, but it round about 20K for a partner session. So that's another saving that we did. And then the other bits of money that came in as well as a result largely came out of the fact that in our practice, we've got pressures with the number of rooms available. So we've grown our list over many years and we've extended and there's not loads more scope to extend. So we were struggling to have room space for all of our clinicians. But since making the change, we've now got several clinicians working from this hub and they can share a clinical room. So if they do need to see someone face to face, they pop down and use one of the rooms, but we can share that room between everyone. And having that extra space in the building opened up some opportunities for other ways to make money. So we took on some additional trainees, which obviously helps both with the capacity, but also with the money, because we get 9K per trainee that we have. We took on a physician associate apprentice who we're training up, and that we get paid 14,000 a year for having him. We also took on some students from the university. That was fairly lucrative. We had them sit in a room and see patients and get supervised by the team from the hub. And we used some of the rooms for other services that would be beneficial to the patients. So things like lead-in ultrasound providers come and use a room and provide scans. The audiologists come and provide scans, and that added as well. And then the other thing that is harder to quantify as well is that we'd actually, because we felt like we were drowning before we switched our system, we actually took a radical step of closing the list. So we were having a lot of registrations of patients partly because one of the other practices locally was struggling, but we felt like we couldn't cope with the new patients coming in, so we closed the list. And as soon as we'd made this change, we thought, right, well, we're managing again now. Let's open it up. So having the list growing, you can't put an exact figure on that, but we're getting £107 per patient per year now. So that's all building into our income as well. And if you total all of that up for us, then it's more than 250,000 of a difference. And that, you have to bear in mind that that's coming off the back of, we're comparing it to a year where we did really badly and then, a better year. But we are seeing that in the accounts that the profit shares are good again now. And most importantly, we're financially resilient and we're stable, and we won't be asking our staff to reduce hours or, not being able to keep on staff, which was a really horrible thing to have to do as an employer. And we won't have to do that again. And we're going to try to run a system where we never put ourselves in that position again.
Yeah, it's a really tricky navigation process, and it's amazing to see how far it's come. It's an amazing story. I'm going to try and combine a few of the questions that have come in, and hopefully we can get through the majority of them. Some of them have been answered just as you've been speaking.
Yeah.
There was one that was, some of the GPs feel that they've now moved to receptionist roles. So this practice has just moved to total triage. And they're saying that these GPs now feel like they've moved to more of a receptionist role. And there was another one that was almost combined with that, which is kind of the percentage of the clinical queries that actually require a consultation and require GP attention. If you could kind of answer them almost.
Yeah, so in terms of the sort of GP becoming a receptionist, that's a really big fear for lots of people, and what puts a lot of doctors off this kind of total triage access model. And I think that depends upon the system that you run. So some places that, and the places that I've visited and spoken to, they're quite, they're convinced that actually you can't have a non-clinician doing any of this triage. It has to be the GP, and they have to be sat there making the decisions and dealing with it all themselves. I don't agree with that, and I think we're a good example of how it can work in a different way. So all of the reception type job is done by one of our receptionists, and I think for lots of the consultation requests that are coming in, that does not need a clinician to deal with that and to triage that. So there's set criteria for what can go to a community pharmacist, and we've printed it out and we've stuck it on the desk next to the admin computer. And anything that fits that criteria, they're totally confident and capable to redirect that to the right service. And to be honest, they're better at that than we are as clinicians, because I can't remember what pharmacists will and won't see some of the time. And then that applies to every community service that we've got. And like I say, some of the stuff they're actually totally capable of knowing whether something's routine or urgent. And the ones that they're not sure about, then they ask the clinician. So you can either add a note on the inbox that it's easy to do on Accurx's inbox, or you can verbally, and we prefer it if it's just verbally, they just say, oh, what do you think about this one? And we can have that conversation and work it out together. So that's that's the way we do it. So if then the patient needs something booking in, or needs an appointment or a text sending, then that's the admin staff member that will do that. It's not the clinician generally. Obviously, we can be a bit flexible if we're extremely busy or something. People will kind of muck in and help. But 95% of my work when I'm in that same day team is ringing acutely unwell patients, or seeing them face to face, or dealing with them in whatever way I need to. I'm doing clinical work. I'm not doing reception work. And there was a second part of the question, wasn't there? Just remind me what that was again. Sorry, Hannah.
It was what proportion of the forms that are coming through actually do then require like a clinician appointment or appointment with a GP? How many kind of can be referred away almost?
Yeah, so that changes throughout the year, to be honest, and changes over time. So obviously in the winter season, when everybody's got coughs and colds, which now school's back, I'm sure we'll be there again in 2 weeks, I think. But that you're going to get a lot more of your consultation requests that are coming in then that are that are needing a same day response. As people who are acutely unwell and need to see someone that day. You also will get loads of additional resources. So often you get stuff through your PCN of like winter pressures money or extended, appointments for whatever. So the game kind of changes a bit. Whereas in summer you don't get as many people acutely unwell, so a lot more stuff coming through is more appropriate for routine. And it also varies day by day. So we get a lot more of our consultation requests on a Monday than we do on any other day of the week. So the good thing is you get really good metrics from Accurx now that improving all the time actually, and it can tell you, shows you with these graphics exactly what your demand is like, and also you've got an opportunity to kind of code things when you've done it, and that will tell you exactly what your proportion of same day things are versus not, clinical versus admin. We tend to find that our admin requests, so things like prescription queries and things like that, we tend to get about 150 a week, and that's usually pretty stable. In terms of medical consultation requests, we get about 300 a week in summer, and then between sort of 400 and 450 through the winter. That, but like I said, we get a bit more on a Monday, so we get about 100 or 120 consultation requests on a Monday at the moment, and then on the other days it's between sort of 50 to 70. Then that's a bit tricky to know exactly how many of those kind of go into routine versus urgent, partly because we don't code it all as well as we should do. But also we sometimes, if the same day team's not that busy, we might sometimes do some quite quick stuff. So if there's like sick note requests coming in and things, we just fire through them rather than booking them in on a list. But if we're busy, we'll just book them in on a list. So we tend to get the same day team tend to deal with about 70 acute patients on a Monday, and then about 40 or 50 on every other day of the week. Now, the one thing I would just add though is that this is only representing our patients in our area, and the way that they behave and the different services they've got, the different health needs, and the lots of factors affect how many people contact you. And often people are really interested in the numbers and how many appointments and how many clinicians and what does that mean in terms of on the day appointments and things. And you use our data by all means with a pinch of salt. Like it's not necessarily going to apply accurately to your service. So that's the part where you have to think, well, how does this fit in with me? What would our patients do? And ultimately you have to basically make a best guess about how many people you need in the same day team. And then I would say it's better to be cautious and put too many people in to begin with, and then if you find that you're twiddling your thumbs, then you can start to restructure it and say, well, actually we don't need 3 in every day, we can take someone out and give them a routine list instead. But it's, especially in that transition period, it's better to be overstaffed in your urgent team so that you've got plenty of capacity for it.
Fantastic. No, that's brilliant to hear. I'm going to steal 1 more minute of your time,
Of course, yeah.
for one last question, which I'm completely open. I'm just interested in hearing your answer. But which is, it sounds like it was Total Triage that improved the situation, not necessarily Accurx. And then how does Accurx compare with the triage? You may well not have tried
Yeah,
them.
no,
I would see.
that's totally fine to ask. So, you're right. So the total triage, I think actually switching to a total triage system is the crux of the thing that will help. And there's different products out there that people can use. There's loads of different ones. We went with Accurx partly because we already had, we were using their SMS service and they were really intuitive and helpful and adaptive to our requests, really. So we sort of had some confidence in that side of things. And also we liked the kind of simplicity and the ease of using the form. So some of the alternatives that we looked at, there are, there's a few out there, and some people prefer the others. That's fine, but often I find them either a bit more clunky and a bit less intuitive, or there's some that tend to try and use a bit more of like AI algorithms to do part of that triage decision for you. So when you enter, the patient goes on the form and they type something in, and it asks, got a sore throat, and then it asks them 10 questions about that, and it takes them a long time to work through all that information, which I think, one, really frustrates the patient because they get a feeling like they're being dealt with by a robot, and two, I just don't really believe that an algorithm can ever really make those kind of soft touch, nuanced decisions that, and we all in primary care, we know all of, a lot of our patients, and sometimes, the way you deal with things might be different for different people. You can't lump them all into something that a computer can decide. So we didn't like the idea of the more algorithm based AI type based packages, and we like the simplicity and the ease of use for Accurx. So for us, that's why we used them. And for the majority of practices that I've worked with, I've actually just done it, not in any way affiliated with Accurx, just discussing more about the kind of total triage. For us, Accurx feels like the best solution, but if you want to explore other options, then I'd encourage you to do that and find the one that fits best with you and your practice, and see which one suits you best, really.
Absolutely, I agree as well. And thank you so much for your time today. I'm going to speak more on your ambassador sessions when we come up to the slide a bit later.
Okay, yeah.
And we'll make sure to reference that. But thank you so much, Adam. It's been really helpful. And I can see that a lot of people are already clamoring for the recording, which will definitely get sent out.
Yeah, no problem. Thanks very much, Hannah.
Well, thank you. I'm going to go through a few more slides now. A lot of these have been answered in terms of these common concerns, so that creating additional demand, the risk of patients with digital exclusion, or whether it's worth the change. If you are interested in exploring any of these more, perhaps more relating directly to your practice, we've got some more information coming up in the next few slides. So here, I just wanted to touch on the things that we have existing within the Accurx inbox that might help with this. Well, I think, as Adam said, it's kind of resoundingly around that workflow and that process. We do have tools to control access if needed. So they do exist in terms of limits and caps. But as Adam mentioned, that can also kind of cause fluctuations with the patient's understanding in terms of how the form works. If you need to rely on something, it is there and available to you when you start off, for example. Using that reception flow to triage patients. So no matter how they get in touch, whether that's the phone or online, effectively the same. And then funneling everything into that one inbox. So it's easier to kind of triage through them all. Here we've got this keen to get started. So we've got a comprehensive implementation guide that's available to you. It's like a pack that you can download. If you do prefer talking to people directly, we've got a QR code that has training with our ambassadors. I'll make sure to send these slides with you with this QR code involved in there as well. We've also got implementation training calls, so you can use these alongside. These are all free for you to access. So please make the most use out of them as you can. We're here to help and here to talk to you about all of these questions that you may have. Another element of this is that back to school season is well and truly upon us. So we've also got the Total Triage University. This is a kind of more handheld process. The deadline is tomorrow for you to sign up. But I've made sure that once this webinar ends, there will be a form that will pop up, an application form with Microsoft Teams. So if you do want to apply, it's there for you. If you don't, feel free to close the browser tab that opens up. But this is kind of just additional support in terms of practices that are looking to go live with Total Triage and kind of explore that process, perhaps with a little bit more support alongside it. I know you've popped loads of questions in the chat today, and I'm so grateful that you have and that we've managed to have a really productive discussion. If you do have any more or yours didn't get answered today, sadly, we have the customer success at accurx.com inbox, of course, those calls that I mentioned earlier as well. But that is it from me today and all the slides that I have for you. If you've got any questions at all, pop them to that email and keep an eye out for the recording and the slides after this. Thank you all so much. Take care. Bye.